On the scene here at the ASCO 2011 conference in San Diego, we have the man with us now who's at the heart of the great deal of excitement out of this conference, and that is Serge Verstovsek, MD, from the MD Anderson Cancer Center in Houston, Texas. Thanks for being with us.
Thank you. Pleasure.
Let's talk about your abstract 278, consistent benefit of Ruxolitinib over placebo in spleen volume reduction and symptom improvement across subgroups and overall survival advantage. The results from COMFORT-I. What is the significance of this data you presented regarding COMFORT-I for practicing clinicians and hematologists?
This is very interesting and very significant news for practicing physicians. As you know, COMFORT-I is the phase 3 placebo-controlled randomized study between Ruxolitinib, recently approved JAK1 and JAK2 oral inhibitor for therapy of patients with myelofibrosis, versus placebo. This is the study that led to its approval. 150 patients were treated with Ruxolitinib and about 150 were receiving placebo in a blinded fashion. And the goal of the therapy was to see how many patients would have significant reduction in big spleen, which is one of the major problems with this disease. And the second point was to see how many patients would significantly improve myelofibrosis-related symptoms over time, which is the second major problem with myelofibrosis. Additional one is anemia, but Ruxolitinib really affects two in majority of patients to great extent. So Ruxolitinib was very effective in reducing the big organs, the spleen particularly, and improving the symptoms, and it was approved on that fact. The issue then was whether all patients of all types of myelofibrosis, regardless of their age, whether they have anemia or no anemia, whether they have a JAK2 mutation, or not, whether they had any other characteristics that would distinct them from the rest, would affect their chance of response. And we present convincing data, very well analyzed data, that regardless of the pre-therapy characteristics, patients have the chance to respond to some extent. Basically, whether they have a JAK2 mutation or not a JAK2 mutation, whether they have anemia, whether they are older or younger, doesn't really matter. Everybody has a chance to respond to significantly improve the spleen and to significantly improve the symptoms. Major advance in terms of therapy. However, the main point actually of presentation is that we see now, after additional 4 months of follow-up from primary analysis that led to approval, that in fact Ruxolitinib treated patients live longer. How is this possible? Remember that patients that have myelofibrosis usually have an average survival of 5 to 7 years. Patients with advanced myelofibrosis, majority of the patients in this particular study were patients with advanced myelofibrosis, have a very short life expectancy, maybe a year or two. They die from the disease itself. The organs, the spleen and liver also enlarge, they lose weight, they can eat, they are cachectic, they have bone aches and pains, itching, night sweating, they end up dying in hospice. This is very terrible, slow death. With this therapy, we control the signs and symptoms of the disease very well in great majority of the patients. We do not eliminate disease. The bone marrow stays still with fibrosis, but we make people eat more, they gain weight, they walk more, they enjoy life, they don't have constitutional symptoms, fatigue goes away, weakness. They're becoming more normal. And with better control of signs and symptoms of the disease, people live longer. And that's the main message, and I think that brings additional quality to this therapy. It's not just about controlling the disease, but with the control, patients actually live longer.
Dr. V, have you ever been involved in anything of such importance and so life-changing for patients?
No. In fact, I have been involved with the myeloproliferative disease area quite some time now, many years, and there has never ever been any drug approved for myelofibrosis because no drug was able to counteract the main problems with the disease. We are talking about anemia, big organs and symptoms. Ruxolitinib is very effective in counteracting 2 out of 3. So it's major advance and people live longer, and it's a good starting point, a building block for a combination studies with new agents, with other agents that may be active in this area, for us to further improve the outcome of these patients. So it's very exciting. It is excellent to have such a positive drug, very effective and safe on the market now for patients that need help.
How important is it for clinicians to obtain laboratory tests for JAK1 and JAK2 mutations?
This is an excellent point. You see, since the 2005, when the JAK2 mutation was first described in patients with myeloproliferative diseases, and about half of the patients with myelofibrosis have a JAK2 mutation, the efforts were put forward to develop JAK2 inhibitors that would potentially perhaps eliminate malignant cells and free patients from the disease. Since then, we found out that the JAK2 mutation is just one of the many. There are more than 10 mutations that we know of present in the patients with myelofibrosis. Many patients have multiple mutations at the same time. JAK2 mutation is only one of many. It is not the cause for the disease. It's just present there. What we know, on the other hand, is that every patient with myelofibrosis have very high activity of the JAK and downstream proteins called STAT. So JAK-STAT pathway is very active in all patients with myelofibrosis, regardless of the mutational status. Why is this important? Because Ruxolitinib is the JAK2 inhibitor that inhibits mutated and unmutated JAK2, regardless. It's not specific only for the mutation, so it helps everybody. In clinical practice, therefore, one does not need to test patients for the presence or absence of the JAK2 mutation. Doesn't matter. Everybody has a chance to benefit in clinical studies, and in COMFORT-1 study, as I mentioned before, patients with or without mutation benefit the same way. No reason to test.
Can clinicians feel confident that Ruxolitinib is appropriate for patients with a standard hematology workup and a physical exam?
This is a standard practice. People who usually are involved with patients with hematological diseases would obtain blood count and do a physical exam in a regular fashion. This is a medication that counteracts the symptoms and the spleen, so it is appropriate, excellent choice for patients that suffer from these problems. In about a quarter of the patients, Ruxolitinib may lower the red blood cell count and or platelets, because this is on-target expected suppression of the count. Remember, the normal JAK2 is involved in normal growth of the cells in the bone marrow, so because this is not specific for the mutation, it does affect normal. How we deal with any suggestion of the blood count being lower than what you want is by adjusting the dose. By and large, patients are not endangered by lowering of the blood cell count. What one needs to do is adjust the dose of Ruxolitinib, and in studies so far, patients were not taken off for myelosuppression. Simple adjustment of the dose is all you need.
All right, Dr. V, let's also talk about your other abstract, number 793, titled Comparison of Outcomes of Advanced MF Patients Treated with Ruxolitinib to Those of a Historical Control Group, Survival Advantage of Ruxolitinib Therapy. Again, you got very positive data here. What is the significance of it for practicing clinicians?
The second abstract complements the first one in the message that the therapy with Ruxolitinib, by virtue of controlling the signs and symptoms, make people live longer. What we have done is we looked at 107 patients that were treated at the MD Anderson Cancer Center in a phase 1-2 study with Ruxolitinib. It's been a while now, about 3-year follow-up on average. And we see that still more than half of the patients that were ever exposed to the drug at whatever dose are still taking the medication and benefit from the therapy by maintaining very small organs, maintaining the control of the symptoms. We then analyzed from historical experience from 2 large university centers in Italy and from MD Anderson itself, the outcome of 310 patients that were matched to these 107 patients that were on the study. So 3-to-1 match for the same characteristics to make sure that we properly assess the overall outcome of the patients in terms of the survival. And indeed, in this analysis, between 107 patients on the phase 1-2 study on Ruxolitinib versus 310 historically matched control patients, we see significant improvement in the life expectancy of the patients on Ruxolitinib, confirming or adding additional information to prospective randomized results, where in COMFORT-1 Ruxolitinib was randomized versus placebo, where we also see survival advantage, and makes us more confident and comfortable saying that indeed people not just feel better and have small organs, but they do live longer.
Thank you, Doctor. Congratulations on your exciting work. Thank you for coming by and sharing it with us, or as I should say in your native Croatian tongue, hvala, right?
Hvala.
Hvala.
Pleasure.
Okay. Thank you, sir.
Thank you very much.
Serge Verstovsek, MD, from the MD Anderson Cancer Center, joining us about the exciting news of Ruxolitinib here at ASH 2011.